Welcome everyone. I'd like to begin by acknowledging the traditional owners of the land on which we meet today. I would also like to pay my respects to elders past, present and emerging. Well, good afternoon and welcome to the July FightMND Scientific Seminar. My name is Sarah Bennett and I'm the Research Coordinator at FightMND. We hold these seminars monthly on the fourth Tuesday of the month. And in June, we heard from Professor Larry Steinman from Stanford University in California. Professor Steinman spoke to us about targeting a neuroinflammatory pathway in MND using a technique that has proved successful in multiple sclerosis in the past. If you missed out on this presentation, it is now available on our website, so you can catch up at a convenient time. So following the talk today, we are leaving plenty of time for discussion and questions. So if you would like to ask anything, please use your reaction button to raise your hand, and one of our team will enable your microphone and camera and let you know to ask your question. Alternatively, you can also type your question into the chat where our team will be monitoring and can read out questions on your behalf. Please do note that the chat function is only enabled if you are using the app-based version of Teams and unfortunately does not work in the web-based version. Please ensure you introduce yourself and where you're from before asking your questions so we can all get to know each other. So now to our presentation for today. Professor Samar Aoun is the Perron Institute Chair in Palliative Care at the University of Western Australia, Perron Institute for Neurological and Translational Science, Chair of Compassionate Communities Australia and Southwest Compassionate Communities Network in WA. She is also the immediate past Chair of MND Australia and MND AWA. Amongst her many accolades are the Centenary Medal in 2003 from the Prime Minister of Australia, the 2018 Medal for Excellence from the European Society for Person-Centred Healthcare, the 2023 Western Australian of the Year and 2024 Lifetime Achievement Award from MND Australia. As an international leader in the promotion and advocacy of public health approaches to palliative care, Professor Aoun's work has led to new approaches for those living with grief and bereavement, specifically for MND. Her research programs have had direct impact on policy and practice at the national and international levels. We're so honoured for you to join us today, Samar. Thank you and welcome, and over to you.
Thanks a lot, Sarah and FightMND for hosting this webinar, and welcome to all the people who are already tuned in. So let me go straight and share my screen, and then I'll feel more relaxed that I'm doing the right thing. Okay, can we all see this one? The first one?
That's great, Samar.
Okay, fantastic. So compassionate communities for MND, what is it all about? Supporting those caring, dying and grieving is in the remit of palliative care. But what is actually happening that we need to improve on, and why do we need compassionate communities? So with palliative care being declared as a basic human right by WHO, we had those questions. Is it accessible to everyone? Is it accessible everywhere? Or is it still an aspiration? Sadly, it is still an aspiration, and especially for those who have non-cancer diagnoses. So palliative care mostly is for cancer and still is, but this is only 25% of the death. So what happens to the other 75%? And of course, MND is in that mix of the 75%. We have this terrible phase that we say hard to reach, but that represents the majority of people who do not have direct or indirect access to palliative care. So it is our duty to reach out to them. It's not the other way around. And of course, psychosocial morbidity should not be ignored, and that is prevalent everywhere, particularly if you have life-limiting illness as well. So when we did this statewide review in WA, the pressure points in palliative care are exactly the same what's in the literature, particularly in Australia. So there is inequity. Non-cancer conditions do not really fare very well in this. What consumers have said is that they need death and grief literacy, not just for themselves, but also for health professionals. Family carer support, they don't feel supported. And of course, we know in MND, the family carers, particularly the spouses, bear the brunt of the caring and the burden of caring. Workforce education and training, particularly MND, people say people don't know about the disease, they don't know how to help us, so we need more training for those health professionals. And then, of course, after death, bereavement support is nearly non-existent. And this is what we're trying to basically call for, because even grief with MND starts from the time of diagnosis, when people, are told, go and sort out your business, kind of thing. So it's really harsh diagnosis that is akin to a death sentence. And of course, the models of cares are not integrated, not for MND, not for other also diseases. So what can we do to do all that? We publish on this as winners and losers in palliative care service delivery. And of course, the MND, people living with MND are in the losers category in terms of service delivery. So here we come with compassionate communities model of care. Internationally, models of social and practical support at the end of life are gaining momentum because of that movement. And so this means we need a shift in the culture of care and support. We can't keep doing what we're doing. Care that is more sustainable and affordable. So it's not about more money for this and that. And therefore, we need high levels of community control and ownership, which hasn't happened now for a long time. So compassionate communities, for a while, we all thought it's an aspiration, but really it's a practice. It is inclusive of everyone. It doesn't matter what disease you have. It's about human suffering. It's committed to system change. And this is why I like it so much, because we really need to have some system change. And it's a key element of what we call public health palliative care approach. This is where the community needs to be looked at as an equal partner in delivering that care. If we don't, we're going to stay as we are now, a lot of gaps. And so let's just see what is compassion first, and we all agree on the same definition. We respond with humanity and kindness to each person's pain, distress, anxiety, or need. We search for the things we can do, however small, to give comfort and relieve suffering. We find time for those we serve and work alongside. We do not wait to be asked because we care. If you are compassionate, and I think most human beings are, this is, we will think this is a really good definition. And Dr. Julian Abel mentioned that compassion is the foundation of good social relationships and is a potential in all of us. It's part of our evolutionary heritage, so survival of the kindest, found in every part of us, genomics, biochemistry, physiology, behavior, social. We have to recognize it within us before we do anything else and recognize that others are the same. So what is the evidence behind compassion being in the healthcare system? So with the research coming forward now that only less than 5% of a person there is in contact with formal care, even for MND. And even, all of you, if you'd gone to a hospital, how much time do you spend with a doctor, a nurse, and so on with allied health? So that's less than 5%. And so what do we do with the other 95%? Who's there for us? And this is what we call the informal care. This is where our families, our friends, our neighbors, our workplaces, our schools are there to support us. But what are we doing with those 95, those who are helping us in 95% of our day? We have de-skilled them because we told them for a while that health professionals do a better job. Now, health professionals do a great job when it comes to clinical work, but 95% of the care is non-clinical. And when you know about MND, again, they cared for mainly at home, and there's a lot of non-clinical support that they need. So when we did the National Bereavement Survey here in Australia, we found that only 10% of people had actually sought help from bereavement support services, being a counselor, bereavement support group, psychologist. 30% thought they, asked their GP, their pharmacist, just had a normal chat about everyday life and told them about their bereavement. And the majority really, they went to family, friends, and surprisingly, funeral providers were consulted quite a lot, I suppose, around the funeral sort of time. So that is the first empirical evidence that we had that compassionate communities are well and thriving, but what we need is more upskilling for them to be able to cover the whole range of issues. So with the public health model of bereavement support, 60% of people would have low risk in developing complicated grief, and this can be dealt with family, friends. Moderate risk, about 30%, they would be in need of some additional support like peer support, volunteer-led group. And then the 10% who are at high risk would need really professional support. So that's changed the way bereavement support is done all over the world, because we've reached a stage where grief was pathologized and medicalized, and you were told everywhere, if you have a death, you really need to go to a counseling service. And then bereavement support services were at a loss because they didn't have the funding to stretch over everyone who's had a death. So now they focus on the 10% who need their help. And then when we ask people about, well, how helpful were those sources of support for you, the blue one is the category that was helpful. As you can see, again, family, friends, funeral provider were in the most helpful people. And then as you can see, the red tend to creep in more with the professional services. So with grief staying around forever, people think that grief slowly gets smaller with time. In reality, grief in reality stays the same size, but slowly life begins to grow around it. And this is where basically the community needs to be supportive and know how to wrap around, you know, the person with grief. And so where did this model go? Basically, it's really gone everywhere in terms of our own peak body had used it in their policy documents. The Irish Hospice Foundation developed their programs and their policy around it. The UK National Bereavement Alliance, again, they've used it for kids in the UK. Then we have the European Association for Palliative Care. They've used it to develop their bereavement care guidelines. And the King's College London, where Cecily Saunders Institute is positioned, again, they kept you know, contacting us and saying how useful this model is. And again, they have practitioners that I meet at, you know, everywhere in conferences that just say, this has been so useful for us. So where to from here? When it comes to dying, we're going to have a tsunami of baby boomers dying all at the same time now in the next 20 years or so. And of course, the reports have come up that many Australians are dying in a way and in a place that does not reflect their values and their choices. And they keep going into hospitals when you don't need to do that towards the end of life, which means they experience a lot of loss of dignity, a lot of loss of control that comes with that. So Professor Alan Kelleher said death is a social event with a medical component. It is not a medical event with a social component the way it has become now, particularly in the Western world. Of course, some of the other cultures are still doing it really well. So this is why last year I was invited to write an op-ed in the newspaper. It won't kill us to speak openly about death and dying. I mean, we have, I don't know if you may have people like me in my extended family. You mentioned the word death and they think they're going to contract it and die the following day. So we really need to change this. We really need to get the community more death literate. And that is the problem that we have here. So dying is increasingly institutionalized. This is the latest figures from the AIHW. And most of the people who get admitted for palliative care reasons are dying in hospitals. So death has become, or modern death has become cellular, curtained, individualized, and obscure. That's why people are so scared of it, because they haven't seen people dying around them like it used to happen in the old days. And of course, when it comes to cost, it's a lot more expensive to care for people towards the end of life. And so what happens to all the advanced care planning, you know, that we have? Millions have been spent on this, really good, of course, thing to do, but the uptake is only about 15%. Why? Because we are asking people to have those conversations when they're about to die, complete a complicated form that comes out of the blue without them having any conversations, you know, during their lifetime. So of course the take-up is going to be very little. So we've put the cart before the horse, and that's why I think we really need to go for a big campaign in terms of improving the death literacy of the population. So 70 to 80% of us, we always say we want to die at home, but 14 to 20% of us are able to do that. And of course, those who are able to do that are the ones who have got supportive communities around them. So 75% of Australians haven't had end-of-life care discussions, and the uptake of advanced care directives is low. And again, the biggest killer that's also coming, well, it is, we are in it, is social isolation and people feeling lonely. So, and that's across all the age groups, really. And if you have a life-limiting illness, you are even more isolated. So we really need to do something about this. Social connectedness impact cannot be overlooked. It is an amazing health determinant, both mentally and physically. People who are more socially connected are happier, physically healthier, live longer, and the opposite is true. This is like large trials. Again, another large trial here showed that if you have strong social relationship, that's more of a protective factor against mortality than if you reduce your smoking, your blood pressure, you improve your activity, you reduce your obesity. Like it's so important. And so this is where it all comes in as the evidence of why we need compassionate communities. It's about building those resilient networks of support around families in need. It's scaling up those caring networks, increasing neighborhood capacity to care for those who are experiencing death, dying, and loss, integrating and building of trusting relationships with health and social care teams, increasing equity of services and financial savings. Of course, we have proved that here in Australia and of course in the UK. So in 2018, in the southwest of Western Australia, we started with the Southwest Compassionate Community Networks. It's a grassroots approach. Myself and another colleague, or another friend in the community, we didn't do it because we're academics or researchers. We lived in that community and we really wanted to see how every person, every family, and every community should know how to do, what to do, and to support someone who's caring, dying, and grieving. And so we started with the Compassionate Community Connectors program, which was a partnership with the health service. And these are the first group of connectors. You could see we're all, it's a COVID picture. We're all standing so far apart from each other because we were told to do so. So the role of the connector is to enhance the networks within those circles of care. So basically you've got the family at the core of everything, and then you got the inner informal network, the outer informal network, the community, and then the professional care comes. So the connectors increase those community capacity around the family to give them the support. They reach out into the community to caring helpers, anybody, community citizens who are able to walk the dog, do the shopping, collect a prescription, and most importantly, sit with that person and have a chat. And this is what was most needed in this research trial. You may think there are small things, but these are really very important for people to normalize their life while, they're either waiting for a cure or, death is knocking at their door very soon. So those community volunteers are trying to diagnose suffering, not diseases. So when you look at the range of help that the connectors and the caring helpers could offer, you could see the social one in red. That is the most sought after. 76.9% of the families who were referred, this is what they sought. So they told, that the people, we don't need any of the other ones, but please sit down and talk to us. We really need to talk to people about our suffering. So what they've done, there's a range of things that was offered to the families in need. Like really encourage them to like, for instance, do all-time dancing, crafts, walking group. There were surrogate grannies for family with kids, transport to medical appointments, gardening, social visits, meal delivery, but the most important thing is that empowerment and ownership. You can do this, because a lot of them have really dropped the bundle and they're not really enjoying living while they're dying. So, and this is what this community-led solution has led people to start, really making the most of the life that they still have. Now, half of those patients were home alone, so they didn't have their naturally occurring networks, but those amazing connectors have been resourceful in their own communities, and they brought in people who are not connected to those families or patients to help them. So 59% of the help came from outside those families. And we have a lot of people in the community who really would like to help. So we measured the increase in social connectedness, and it was quite significant in terms of social emotional gain and practical and tangible gain before and after the intervention. Again, while their dependency, because they have unmet needs, stayed the same, their availability of network support had doubled in the 15 months of the data collection that we trialed this. Again, when we asked them what impact this has had on you, as you can see, reduced social isolation has been quite high. And then we asked the connectors the same questions, but the connectors as volunteers always try to dismiss their impact or minimize it. And that was really good for them to see how much the families had appreciated them. So this is a family before the intervention, where, you know, these are the people basically around them and who they talk to. And then when we had the connectors and the caring helpers involved, you can see all the buzz around this family. They were talking not just to the family among themselves, how they can support the family in what ways. So in terms of healthcare usage and economic analysis relative to controls, the intervention group who were cared for by the connectors had significant decline in the frequency of hospitalizations, significant decline in the number of hospital days, significant decline in EG presentations, and significant increased use of outpatient services. Of course, it's a lot cheaper for people to go to outpatient service than hospitals. The reason being is that when you have somebody, say, with, you know, COPD, and they feel that they can't breathe, they can get really anxious, and for some reason, but because they don't have anybody, they used to admit themselves over the weekend. But now they've got people who love them in the community. They call on them, the people come and stay with them, and therefore they can wait till, say, Monday to call their outpatient service and talk. So again, and then when they went to hospital, they didn't want to stay as long as they did before, because again, they're really eager to go out and be part of that lovely community that they have around them. And so the increase in the use of outpatient services was due because those lovely people in the community were able to make those appointments for the terminally ill people and also drive them there. So that way they were seen in good time before they became into crisis and had to admit themselves to hospital. So the savings for the health service were just over $500,000 in 6 months if we had 100 patients, 20 connectors, and 2 coordinators for those connectors. It's not small, just by having people in the community helping. That's why we need to have the community as part of delivering that care. There are gaps, so obviously they were filling those gaps, but saving the health service quite a lot. That's a picture of somebody helping with home card making at home. This is a intergenerational church group who wanted to help, you know, this elderly gentleman who his garden was his life, and he became too depressed because he couldn't really do anything to it. So what is so distinct about this form of volunteering? It exercises more autonomy, has more agency in providing care, and it's sustainable social capital emerging from genuine social encounters, and it's fresh ways of engaging in the community. So basically, our connectors really loved it. It's not tied into the traditional way of volunteering in hospice and hospital, when you say the X amount of hours I have to do, certain days, certain. It's the way you help each other in the community, and we need to go back to that way of doing things. If you look at all the information, and the articles are all on the website of the Southwest Compassionate Communities Network. Now, to get the community more involved at a larger level, we worked with local government to develop a compassionate charter for the city. We call it Compassionate Bunbury Charter. So that way, a lot more people heard about the Connector program, and it was more like a call to action. How can you do more compassionate acts in the community to help your community? And we gave them also a toolkit to give them ideas how to do that. And we worked with the mayor to have an award, a mayoral award for the most compassionate school, workplace, act. And we're going to launch it on Compassionate Communities World Compassionate Communities Day, which is on the 1st of November. So this is what the community have said, and I don't think it's going to be different to any other community in terms of how do we grow compassion wherever we are, in terms of building capacity to give and receive, mobilizing networks of care, get the good communication flowing, respecting people's wishes, fostering belonging and connectedness, providing opportunities to remember. Again, the arts sector, the workplace, they all need to be part of that. Why? It's important because it's a systemic way of ensuring we build compassionate communities in all sectors. And also we need to, start, showing what we are doing so that people can, follow through. It is a concise way of organizing a purposeful program of civic action oriented towards end of life. So this is so important for compassionate communities, for MND. If there is a disease, MND would be the disease that they need the love and support of everyone. So until there's care, until there is a cure for MND, the focus needs to be on quality of life, quality of care, and quality of death. And again, as I said before, how do you maximize the living while you knowing you are dying? So we did another national MND bereavement survey. 393 people responded. This is to the bereaved carer to ask them about their experience after the death of their relative. So really, we published something, and the family carers, some of them were traumatized, the majority of them traumatized, angry, abandoned, but some felt empowered. So what really made this difference in the grief journey that starts from diagnosis? We looked at the psychological morbidity, and this is 2 years after their loved one had died. So they still had anxiety, depression, and there was still some family dysfunction. Now, the risk factor for complicated grief for MND were many, but the ones I want to focus on are the last two. The ones who have had a shorter period of caring, they again had a higher risk of complicated grief because they didn't have enough time to prepare for everything, and of course the help doesn't come that quickly. And again, those who said they had insufficient support during the disease journey. So when we look at that, again, the public health model, on the right is the general survey, the left is general survey, the right is the MND survey. You could see more of the bereaved carers are in the moderate risk for having complicated grief or the high risk compared to the general bereaved situation. And again, those who have had enough support, they tend to be more in the low risk category, while the ones with a high need are in the low, and not enough support, they said they're in the high risk category. Again, those who have done well in terms of physical, mental, and financial health are the ones who had sufficient support as well compared to the other ones. So this is a similar sort of a graph but focused on MND family carers who helped them. Family friend funeral providers came at the top. GPs had a bigger role there, and of course MND associations, they do an amazing job helping families. And the MND associations are crucial because they actually are the only ones who are able to connect those families to the health professionals and to the community, and get that corridor of work, of links happening between health professionals, the family, and the community in general. Again, when we ask MND bereaved carers, as you can see, the majority thought family, friends, and funeral providers were in the groups. Again, the MND association came as really very helpful as well. So somebody at low risk would say, for instance, I was very fortunate to have the friend and family I have. They have been with me wherever I needed support, distraction, or someone to reflect with. So somebody at low risk, they're saying that they had really this good support. Somebody at high risk will say something, it's difficult suddenly living alone and a feeling of loss of purpose. Nothing prepares you for being alone. People say go on holiday, but not having someone to share the experiences with makes it a sad experience, not a happy one. I spend a lot of time carving a small headstone for her grave. So it's all been published. I won't go through that. And when I looked where do the MND deaths happen? And really, I've only asked those 3 associations. About a quarter are dying at home, another quarter at the hospital, and the rest hospice, palliative care unit, nursing home. Now, when you think about people with MND, their care is mainly at home, and then they end up not really dying at home. Again, where is the community around them to support this happening? Because everybody really, this is where people want. Of course, there are other choices, but the majority would say that. So when we did the work here in WA, the gaps in service and unmet needs were about insufficient integration of services across health and community care, unequal and poor access to a coordinated palliative approach to care, significant gaps in the knowledge base of the workforce, a failure to meet the consumer expectations of person-centered care. And I really want to add this network-centered care, because without their networks, they're not going to be able to have the help they need. Let me tell you some of the quotes that our MND bereaved carers have volunteered in the survey. Our care was chaotic. No one knew who was doing what, no coordination. This started from the diagnosis of MND, continued through his discharge from hospital without adequate home care plan, incorrect referrals to inappropriate services, and then totally uncoordinated care. The nurses were not used to having someone with MND. Some of the nurses were lovely and apologizing for not having the training they needed. I would have to help them hoist him. Staff said they were used to cancer patients who were easier to look after. The system is broken and needs to be fixed. MND is a diagnosis that needs its own system to help understand the impact. The systems are very flawed, and for a 69-year-old to be forced into a nursing home is terrible when he wants to be in his own home. The nurses would go into his room but didn't understand him or know what he wanted, so they got frustrated with him. I overheard the nurse telling him off because he tried to phone me to come back to the hospice. I was very disappointed with her reaction. I sat by my husband's bed for hours on the day he passed away. I thought he was just really sleepy. A nurse walks in and said he's gone. Nobody bothered to say he is slowly dying. They must have known. I could have called family for some support. He wanted to be at home. He had the right to be at home, but that meant my mum had to quit work and be his sole carer. She had to be in his earshot 24/7. And again, if she hasn't done that, he would have to be driven kilometers away from his home. The physical reprieve my mum got was when I was there to take over for her for a few hours, which was most helpful. Thought dad was demanding and often only wanted mum to care for him, but having friends visit to break up his day made difference for us all. So this is when the community is able to help. And as you can see, when we ask them what are the sources of your informal support, family, friend, neighbors. So we published on this, and we are hoping to repeat the survey now at the national level with the help of a grant from FightMND, which we are very grateful for, and see how we can get all the MND association and all the palliative care association organizations be part of looking at this model of care that is going to be suitable for MND and perhaps, for other neurodegenerative conditions. So we really need to rethink care at end of life. We need to have a compassionate communities collaborative model. So we've got all these services on the right that needs to be integrated, and they're not. We've got the enablers, and some of the enablers and important enablers are the compassionate communities and the MND associations and other not-for-profit. We need to have all that working around those circles of care where the community is. And Dr. Julian Abel this is another way of looking at how specialist palliative care, generalist palliative care, compassionate communities, and the civic programs, that's something that we've done with local government, can be part of delivering that palliative care. So for that system change, all these need to work together for more effective, affordable, and sustainable end-of-life care system. How do we prepare the community? We need to have training programs in network mapping and network enhancement. For professionals and community members. We need to support the use of community-led advanced care planning within the networks built to sustain community end-of-life care, and program to train community members to support the end-of-life care and know how to use public resources like the Connectors programs have done. So really, dying at home, it takes a community, and we need a good death literacy program. And Dying to No Day with the Groundswell and Provida they do this every year now, and we have things happening in August throughout in all of Australia, basically, to improve death literacy. We have death cafes. I'm sure you've heard about them. This is something that we've done in the Southwest, a death festival. We had an art competition for the schools. We had a forum on building connectedness to discuss how we do this in WA. We're always in the paper, and these are our lovely connectors there. Talking about reducing social isolation. Palliative Care Australia had a film called Live the Life You Please. We promoted that as well for people to know. We have those Remembering the Dead ceremony where we have the floating lanterns with our loved ones' names written on it. We have a concert at the cemetery so that people are not too scared of going to a cemetery, breaking those taboos and the stigma. We have some historical tours there as well about what's happening to the people who lived in the area. We started work with workplaces, how they can be compassionate, and we delivered advanced care planning and grief support program to them. This is our mayor here, a very young mayor with his shorts. He's giving compassionate awards to the connectors, who were the first ones really to do this work in our area. And we have a cooling blanket that we got through a grant. So if people want to leave their dead loved one, deceased loved one at home for a few days to basically reflect on their loss and do their final goodbye, the community can borrow this. So this is how we build those, the visibility of people need to help each other and the compassion in community. Is this a solution to the aged care sector, aged care crisis? Again, 60% of MND people are in that category. Yes, they say, yes, we need increased integration between aged care facilities and the community. But who is going to do this integration? I mean, I go to palliative care conferences every year, and the call every year, this system is not working. We need a paradigm shift. But it's up to us. We really need to do it ourselves. We can't just keep saying the same thing in all the conferences that we attend. So a palliative approach to care, it's about the vital role and support of family carers and those friendship networks. The involvement of the MND Association, the education and training of general health and community care practitioners, and really good connections between the informal caring networks and the formal caring. This is an educational program we did in WA. We visited 7 regions, 321 health professionals took part in this. And this is what we covered in our tours in terms of what is MND diagnosis. And we looked at psychosocial care, a palliative approach to care, physio, nutrition, occupational therapy. So that these health professionals who might see an MND, a person with MND, not that often, if they get one in their care, they know what to do. Again, with the MND Association in WA, we talked about starting a compassion community helpers group. So that's still on the cards to do. So really, when it comes to social support, that's not the same as merely being in the presence of others. The critical issue is reciprocity, being truly heard and seen by the people around us, feeling that we are held in someone's mind and heart, for our physiology to calm down, to heal and grow. We need this visceral feeling of safety. No doctor can write a prescription of friendship and love. These are really complex and hard-earned capacities. So time for community-led solutions. I've given you the example of one. And then because there was so much interest in that, we started Compassion Communities Australia so that we can weave compassion and connection across Australia as we live, die, grieve, and care for one another. And really, if you go to our website, you will know what it's all about. But we want it to become a hub of knowledge and skills for community-led solutions that would lead to social and system change. We've had a lot of people join, and the aim is to develop as many compassionate communities as possible across Australia so that everyone knows how to care for someone who's dying and grieving in their communities. So Give a Family a Fish is a charitable act. Teach a family to fish, that is sustainability, but organize a community-based intergenerational fishing collective, that is social change, right? But how do we get there? You never change things by fighting the existing reality. To change something, build a new model that makes the existing model obsolete. And this is where we need to get to in terms of system change and social change. So with this end in mind, we need to ensure that when caregiving, dying, and grieving knock at our door, wherever we are and whoever we are, that compassionate support will be found in all aspects of our lives and death. The problem is, we really need to put passion back into compassion. This is what it's lacking. We have a lot of compassionate people, but not a lot of passion about it. For the reasons that I've explained before, we have been basically restricted by all this risk aversion, by all these systems that are not helping us well. So come on, community, get this passion and, change the system, because supporting those caring, dying, and grieving is absolutely everybody's responsibility. Thank you.
Thank you, Samar. That was on time. Thank you very much for your talk. So for the people in the audience, if you'd like to ask a question, feel free to type it in the chat box or raise your hand and we'll unmute your mic. And I guess I'll start off with the first question. So you mentioned that you and a friend created the Southwest of Western Australia Compassionate Community as a grassroots activity. And was that more of a regional remote area?
So Bunbury is the regional city in the southwest, and it's the main hub for all of the southwest. So it is a regional and rural area.
And do you think if that same grassroots activity had started in a metro area, do you think you would have seen the same type of success?
Given there are different, I get asked this question a lot. Certainly, this model that we did in the Southwest worked well because we knew the community knew us, and so on. What we're doing for metropolitan areas, we are going through local government because they're the closest level of government to communities, and they have a lot of compassionate programs that they do anyway. So yes, I've gone around and presented to a few of them. So it's just a matter now, and everybody said, okay, well, how can we start a connector program? We've got all these volunteers in so many of those programs that we have. So I think this is one model that will work for metro areas. And we'll let everybody know once we get to that stage.
Yeah. And with the connectors that you had in the Southwest of Western Australia community, did they undergo a specific training program to deliver their volunteer services?
Yes. So we had a 2-day training program, but not 2 consecutive days, so that they know about, because it's quite an interesting concept. The connectors are not the ones who are physically helping, because they're the ones who go into a family and say, okay, who is your network and who do you have around you to support you during your end-of-life care journey? And if you can't ask for help, I'll do the asking on your behalf. So either the families would say, right, yes, I have, Bob next door who could do the mowing of, sort out my garden, but I don't feel I can ask him. So the connectors do that for him. So they bring in people from the community who could do those tasks, but organize it for the families, because really what we need them to do is to keep moving from one family to one family, enlarging those circles of cares for them. So, but they do become friends with the families as well as the caring helpers. It's really the old system, the old way we used to live and care for each other. It's not rocket science. But we've moved away from it, and we really need to go back to that.
Sorry, I'm just looking at the comments in the chat box. So Cheryl is just thanking you for your talk. She says that she is inspired all over again every time she listens to you. And Vicky convenes a young onset dementia network based in Perth with 130 carer couples and some singles, which provides peer and social support, and it works well. I have a question about the funding. Who normally funds these types of, how much funding is required to set up a compassionate community program such as the one that you set up, and who would normally fund this?
So the only funded position is the coordinator of connectors, because he or she will get those families referred to her, and then she needs to match them with the connectors. So they need to know their connectors really well, and also the families really well. Now, in the Southwest, we tried a model with the health service, which basically, this is where we got the referrals. And we got a grant to pay for the coordinator of connectors. Now we are going to trial another one from community referrals, working with community-based organizations. And so we will see, that's on the understanding that it's going to become sustainable in that sense, by doing more community fundraising and, that sort of kind of activities that they anyway do as community-based organizations. So this person would be part of that community-based group. Yeah.
I have no other questions. Does anyone else on the Sarah?
Hey, Samar, can I just ask you a quick question? You did mention sort of early on in your talk that a large percentage of elder Australians haven't had a conversation about end of life. And I was just wondering, about how you sort of initiate or approach those conversations. They're obviously difficult conversations. Do you have any advice for people, whether we're living with MND or not, about approaching those conversations?
I mean, I know in WA and everywhere, we've like palliative care WA has been funded by WA Health to go and do those community workshops and to help people understand the need for advanced care planning. And with further funding from Carers WA, they were able to employ a staff member who would sit with the families and make sure they know how to complete their document. So there is a lot of things that, people can help. So again, in the Southwest now, after we do the initial workshop, we are going to have people help people, fill in those documents with them, basically, because it doesn't. I mean, it helps in your knowledge if you attend a session, but then you go home and if you don't feel it, this is where the problem is. And so, and then when we have all these activities that I mentioned at the end, when people go to death cafes, and those conversations start happening there, because people who have loved ones die, they get asked the questions: what did they do? How do you prepare for it? What's your advice? So that's how the literacy of the community starts developing.
Yeah.
But people have to go there or listen on, online if there's a lot of these advanced care planning workshops happening. So that's and again, with Dying to Know Day now in August, there's a lot of activities that are going to happen. For instance, we are going to feature a movie about a person who died and how his medical team and the community rallied around him. So by watching things like this, it's free. So basically can just, it's being advertised on LinkedIn. And if you go to Compassionate Communities Australia, you'll find the link for that if you want to watch that movie. So that's part of, how people can get educated on how to do things.
Yeah, thank you.
Thanks, Samar. We've got a question from Yumi. Yumi, you should be able to turn your camera and mic on.
Yes. Can you hear me? Yeah.
Yes.
Thank you so much for your presentation. This is my first time, and then it was the great knowledge. And my question is, I'm a PhD student at the Flinders University, and my topic is end of life decision making in Japan. It's more like how appropriate culture, what is the appropriate care for has a different culture background. Then I felt your passion. Then also I found some strategies. Thank you. And my question is, when you are saying like culture can't change, culture gradually, but it's very takes time. And example, in Japan, the prognosis, diagnosis, and the medical information not going to the patient sometimes. They goes to the family-centered decision-making. So, well, my outcome is really promote for the options like legal frame, advanced care planning. That was what I am aiming. But my question is how would you do that for the going to be the social change? You were talking about some strategies and framework, but it's a big issue. So could you just talk to us, please, about for the, like, it's not the individual, it's a culture. What is culturally appropriate?
Yeah, and some cultures, Yumi, do it better than others. Like, if you look at our indigenous communities here in Australia, they really do death and grief really well. They take time, to reflect on their loss, to be with each other, to support each other. Some other cultures like the Maoris as well, So again, so Japan is going to be different, obviously, from what you are explaining. So when do you start those conversations? You really need to start them early. I mean, I think in a way we've lost an opportunity with our older people, because it's just going to be so difficult shifting the way, they want to do this. So this is why, we are, getting more sporting clubs involved, more schools involved, so that they can start talking about death from an early age, and, telling people, do not prevent your kids from going to the funeral, of their granddad or grandma, they need to know about all these things. So it's going to be gradual, especially say, from what I understand in Japan, it still has got a long way to go in terms of, a change of culture, but it needs to start from somewhere. So I guess the more you can take in from what's happening, what we're doing as Compassionate Communities Australia here, and of course other organizations, the more you start that death literacy, infiltrating the death literacy and grief literacy in your communities. It's not a sprint, it's a marathon. So even here in Australia, where we think we are probably, doing well, it's not a quick fix. but it's just a matter of, and that's why we have those, invite people to come to a concert in a cemetery. I mean, we could have the concert anywhere, but again, it's about breaking those taboos and stigmas so that people do not feel scared. And then once they've survived their visit to the cemetery, they think they're not going to die if they go there. They will start then, thinking more about why was I scared? What's in it? How can I prepare for my own death? What is it I want? They start talking about their values and their choices. And these are the things where we could start from. What matters most to you when you are healthy? And what would matter most to you when you are ill? How do your priorities change then? So these are two good opening questions that you could have before you go to the rest of the advanced care planning. Because if you don't know what are your values, it's very difficult to keep the conversation going into other things. But do people know what are the choices? That's the other point. They need to know that they have choices. Of burials, of there are a lot of choices now how you want to do things. So that's my advice. How you take it. In your own culture, basically.
Yeah, thank you.
Show them move. Yeah. Thank you, Tom.
Thank you so much. Like Australia is much more advanced. 20 more years. I just always start. Let's talk about death. What is your decision? That's what I am trying to bring the conversation. Thank you so much.
Well done and good luck.
It's
a lot of work, but needs to be done. Yeah.
Thank you so much.
I don't think we have any more questions. So Samar, thank you so much for your presentation. I think what we'll also do is we'll get Samar to send the links to the Compassionate Communities Australia to us, and Sarah can send it out to the audience members today, as well as a recording that will be done in a couple of days, I believe.
Yeah.
Yeah.
That's a fantastic idea.
Yeah.
Perfect.
So Samar, thank you again for your talk today, and we will talk. We will talk to you soon.
We'll keep talking. Yeah, I know.
Yeah,
Thanks a lot, FightMND, for this amazing opportunity, and again, thanks for sponsoring the projects that would lead to compassionate communities for MND, and also I think it'll be the same for other neurodegenerative conditions, particularly with Vicky questions for early onset dementia. I mean, if we can prove that model of care is the right one, it works, I'm sure it's going to have much wider applicability. Yeah.
So
Great.
thanks. As mentioned, we have recorded today's session. So if you know of anyone who wasn't able to attend live but would like to catch up, please let them know. They will be available on our website in a few days' time. So I'm sure Samar would be very happy to get in contact and discuss further some of her work. If you'd like to get in touch directly with her, if you would like to help us if you would like us to help connect you, please feel free to get in touch with us and we can help set that up for you. So thank you so much for coming today to the July FightMND Scientific Seminar. We really hope you enjoyed today's presentation. The seminar series will be going on a brief hiatus and it won't be running in August due to a clash with the Australian and New Zealand MND Symposium, which is occurring in Melbourne on August 27th and 28th. The seminar will be back in September with a new speaker and more exciting research. So we really hope to see you then. And until then, take care.
Thanks everyone.
Bye,
Thank you.
everyone. Bye.